I'm very humbled to be talking to an audience like yourself. I mean, it's very humbling as a clinician to look after patients like yourself. And I'm grateful to Claire for the opportunity to speak. I did have a slight heart sink when I was given this topic because it's huge, managing the side effects of therapy. So it's going to leave some of you dissatisfied, and I apologise for that. But I have to somehow sort of accommodate as many people as I can in 20 minutes. So what I'm going to talk about, broken it down into 4 parts. I'm going to talk about symptoms that patients experience on therapy, and try and break them down to try and work out, when you're telling us what you're experiencing, to try and work out what, as clinicians, we try and glean from that. Is it a disease-related symptom? Is it a therapy-related symptom, which is what the basis of today's talk is? Is it a symptom that could be either, or is it something that's possibly non-specific or completely unrelated? Then I'm going to look at important side effects that are common to several treatments. So it's not common side effects, it is important side effects that are seen across several of the different treatments, so they happen for many different agents. And then I'm going to look at important side effects that are, and I've put inverted commas, unique. No side effect is particularly unique, but I would guess it's commoner for specific agents. And finally, I had to put this in because I felt if I didn't, you guys would think it was a cop-out. And I felt because I've got to look at fatigue, because it can be a symptom of disease, but it can be a symptom of treatment. But thankfully, Alice has done a very good job of actually pre-saying a lot of what I was going to talk about. So if you go on to, hopefully, we've talked about Health Unlocked, so it's the largest social network for health. There's a section on it with MPN Voice, moderated, so you know that what you're getting back is not going to be largely nonsense if you just go through Google. And if you put in a search term, side and effects, you get something in the region of 1,000 to 1,500 posts with people logging symptoms and effects of their treatment. And the sort of themes coming through are such as I have these symptoms, I report them to my clinician. The clinician says it's not due to the treatment, but it's in the patient information sheet. So there's a confusion there. There's often a discussion about whether there should be a modification in diet or taking vitamins and supplements to help, and I'll try and touch on that. And then whether you should actually change your therapy based on your symptoms or indeed stop therapy. And again, that's something that I'll hopefully touch on. So the symptoms that you give as clinicians, when you give us these symptoms, this is how I think about it. So there are symptoms that you give which are, to my mind, clearly disease-related. So they're just inherent in the condition that you've got. And then there are treatment-related effects. So when you describe them, it's clear that it's likely to be something that we've given you. And then you get these sort of shared symptoms. So fatigue, as I've said, disease-related, but can be therapy-related. Anemia, so myelofibrosis, for example, causes anemia. So that's the disease causing it, but therapies can cause anemia as well. So myelofibrotic therapies can do it. So that's this sort of shared, if you like, cause. And then there are, I should put a question mark in somewhere, because someone's going to say, I think it's that or that. Who knows? But you could put a number of symptoms that you give, which it would be very difficult for clinicians to specify. So I'll call it non-specific, possibly unrelated. And I would guess of the audience that's here, of patients, I would guess that if you are on therapy, my prediction would be probably 3/4 of you are on one of these agents, and all of them have a side effect profile. It's impossible, as I've said, in 20 minutes to outline what those each of those agents and what they would do in detail. So I would direct you to the MPN Voice website, and under the tab for About MPNs Treatments, there are very comprehensive patient information sheets on the treatments which outline their potential side effects. But what I'm going to do is, as I've said, pick out side effects that are common to several drugs, and then side effects which are, if you like, commoner for specific drugs. So we're going to look at, I'm going to try and do it as briefly as I can, but I've picked what I believe to be the important side effects of each of the commonest agents that we use in MPN. can't cover them all, so there will be people in the audience on these other agents. Unfortunately, I can't cover them in detail because it won't apply to the majority of people in the audience. Clearly, these are not, I'm not saying, this is not an exhaustive list of side effects. So clearly, these agents cause other things. These are what I believe to be the important side effects. And I'm going to focus, anemia is part of, it's just one aspect of any of these treatments can lower your blood counts, but I'm just going to pick on anemia. So looking at what are the side effects that are common to several treatments, and anemia and skin cancers are common to several of the MPN treatments. So anemia, I've highlighted, it can be disease or therapy related, but it's a predictable side effect of several of the treatments. So two treatments, so for example, ruxolitinib and anagrelide, we know that patients, when you put them on treatment, we know it's going to produce a degree of anemia. The severity will be different amongst people, but it's predictable. But it can occur with any of the MPN treatments. You know what the symptoms of anemia is, and I guess this comes to where when, some people will say, well, I feel faint and dizzy, and so I've told my clinician I could be anemic, and they've said it's not that. Well, so it's our responsibility. So you can see that these symptoms overlap. So yes, they are symptoms of anemia, but they overlap with many other conditions. So our job as clinicians, if we find that you're anemic on a treatment, is reverse things that we can reverse. So look for coincidental vitamin deficiency, so iron, B12, folate. There's no value in taking these supplements if you're not deficient in them, and as we'll come to, if you have a good balanced diet, there should be no reason for you to be deficient, but it would be amiss for clinicians not to check for the common vitamin deficiencies and replace them. But ultimately, if you become anemic on any of these therapies, we may need to dose reduce your treatment. And in those patients who have more severe anemias, we have to counteract that anemia, and we can do it with several different strategies. But erythropoietin injections, so EPO injections, the stuff that the athletes use to cheat in the Olympics, we use that for you guys to improve your blood counts. And if your anemia gets to significant levels, there's a small proportion of you who will require blood transfusion. The other effect that's common to several agents is the story of skin cancer. So these skin cancers we see in MPN patients are non-melanoma skin cancers. So they're the most common skin cancer in the fair-skinned population. There is a predisposition in fair-skinned people and people with more moles and freckles than you would normally expect than other individuals. If you have a personal history of skin cancers or a family history, there's more risk. And if you've got other pre-existing medical conditions, so if you've got sun-damaged skin, for example, actinic keratosis, then you're at an increased risk. But there are treatments that will increase your risk. And for MPN, the two treatments that I think of for an increased risk are hydroxycarbamide and ruxolitinib. So what are the risks? So for hydroxycarbamide, it's essentially seen in an older age group. It's essentially those who've had excessive sun exposure, so you often get it in the sun-exposed areas, and it's usually associated with higher doses of hydroxycarbamide and over a long, prolonged exposure period. And there is an association between skin cancers, hydroxycarbamide, and UV radiation, so that's the sort of thing you'd get on sunbeds, so that's a particular risk factor. Ruxolitinib also increases your risk of non-melanoma skin cancer. So this was a 10-year, if you like, look back on patients who developed skin cancers, and they looked at the cohort who were exposed to ruxolitinib and those that weren't, and they found that the ruxolitinib cohort were about 2 to 3 times more likely to get a skin cancer than the cohort who were not treated with ruxolitinib. So what's my advice to you guys? It is to protect yourself from the sun. Cover up and use high-factor sunscreen. Be vigilant for any skin abnormalities, and this comes from the NHS non-melanoma skin cancer website. So it says, be vigilant for any skin abnormality, a lump, an ulcer, or a lesion, or discoloration that has not healed or changed after 4 weeks. And we have in Liverpool, for a specific cohort of patients who we feel are a particular risk of skin cancers, our dermatologists do a skin surveillance clinic, so we can refer them and put the case forward for those patients to be screened. So now I'm going to look at important side effects that, if you like, unique or maybe just common to specific drugs. So for hydroxycarbamide now, the two I've picked, we've talked about anemia and skin cancer. We're now going to look at mouth ulcers and leg ulcers. So mouth ulcers, get them on your lips, tongue, gums. They're common. We all get them. So, the MPN population get them, but, the non-MPN population get them too. And that's because there are lots and lots of causes of mouth ulcers. So there can be local damage to the mouth that can do it. So just trauma, ill-fitting dentures, spicy foods can cause ulcers. But there are medical conditions that can do it as well. So, the cold sore virus we associate with the lip, but it can actually cause oral ulceration as well. Vitamin deficiencies can do it, and systemic problems can do it. But medications can do it too, and hence the inclusion of hydroxycarbamide with mouth ulcers. So what do we advise our patients when they get mouth ulcers? Well, the first thing is if it's troublesome, seek a dental review. Make sure it's not anything local that's causing the problem. And if your dentist is happy that there is nothing local, then speak to your haematology team, because they should be looking for other things that might be associated with mouth ulcers. And in some patients, when we can't quite work it out, sometimes we have referred patients, so if we think there's something else going on, we refer them to our Department of Oral Medicine in the dental hospital, and they will look and exclude any weird and wonderful causes of mouth ulcers. But hydroxycarbamide, recurrent mouth ulcers, no obvious local problem. It's going to be the drug. So what do we recommend? Oh, hang on, what have I done now? So we recommend good oral hygiene and dental care, and then just get some over-the-counter preparations, so just Bungella, Corsadol mouthwash, Nystatin, and just see if good mouth care sorts your mouth ulcers. But for very persistent and troublesome mouth ulcers, we have given short courses of a steroid. So betamethasone is a steroid tablet. We dissolve in water. You don't drink it. You just use it as a mouthwash 4 times a day for a week, and it usually sorts it. But if I'm finding myself prescribing recurrent courses of betamethasone, then this isn't working. We need to consider changing therapy. The other particular specific effect for hydroxycarbamide that we see is leg ulcers. And so this is the sort of thing that you might see, usually around the ankle bone. It's very rare, all right? So it's not something that we would see very often. A very small proportion of patients get it. It's usually associated with long-term hydroxycarbamide use, so we warn all our patients about it, and I don't blame them. It's not uncommon for a patient, within a month of therapy, phoning up saying they're concerned about a leg ulcer. That would be vanishingly unlikely, but I understand the concerns. It's caused by hydroxycarbamide-induced DNA damage to the bottom layer of the skin cells. And these are painful ulcers, usually around the ankle and bone joint, as shown in the previous photograph. But what's unique about these is they don't respond to conventional therapies. And so one of the things I've noticed is we have had patients who, some of them are on remote review. You phone them up, they tell them they're fine. They don't tell you that they've been getting a leg ulcer treated by the district nurse, because they just didn't make the association, because it's 10 years later. But they're painful. And the thing about them is they say, oh yeah, it's been treated for 6 months, it's just not healing. They don't respond to conventional therapies. They will not heal until you stop the hydroxycarbamide. And that is an intolerance that would usually then require you to stop therapy and switch. So then, on to specific side effects of the other agents. So I've picked 4 for ruxolitinib. So we've talked about anemia and skin cancer for Rux. These ones, so headache is a reasonably common side effect. I didn't realise until one patient, it was particularly troublesome. Went to the GP about it, and it's in the SPC, but it hadn't clicked that was the particular problem. But now we're switched on to it. Clinicians know about it. It's usually an early effect, often dose related, and it settles with time. It's troublesome, but no more than that. Weight gain is a real phenomenon, and some patients have actually we've had patients who are doing great on Rux, but they say, I'm not taking it anymore. I'm not taking it because it's causing intolerable weight gain. And we used to think, well, that's that's a good thing. Like, you're feeling better, you're eating more. No, it's not. This is a biological phenomenon, and the phenomenon is that ruxolitinib blocks this hormone leptin being produced from body fat, and leptin is the brain signal to tell you are full up. So you don't get that brain signal, and therefore you eat more. So weight gain it's actually being driven by a hormone, and so it's just to be aware if you are gaining weight and to modify your diet and exercise to compensate for that. Infections are also an issue that you should be aware of. So shingles is the one that we think of the most. With regards to that, and many people, certainly in our local practice, we give everyone acyclovir, because if you've had one bad case of shingles, it sort of taints your practice. But not everyone will give prophylactic acyclovir, so don't worry if you're not on it. But if you have a history of shingles, then you probably should be on it, and some clinicians will just give you acyclovir hand in hand with your ruxolitinib. But all infections with ruxolitinib should be treated. So there's an increased risk of infection throughout the period. It doesn't reduce after a year or 2 years, or it's a continuous risk. And so if you have infections, they should be treated promptly. And the one thing to know is if you are being treated concurrently for infection, don't stop your rux. Speak to your clinical team, because stopping the rux will cause a rebound in your disease-related symptoms. And the last thing I want you to be aware of, because it's something that I'll hands up. We are not diligent yet about in our practice anyway checking lipids. We do it intermittently, but ruxolitinib causes hypercholesterolemia or hyperlipidemia. So, and that's a cardiovascular risk factor, and you've had a talk on that earlier. So these should be checked intermittently. So if you're on rux, you should speak to your clinician and say, are you checking my cholesterol regularly? How regularly? That's up for debate, 4 monthly, 6 monthly, but it should be done intermittently, and it should be treated. Interferon. So the two interferons that are used, most people will be on, if they're on interferon, will be on Pegasus, but there are a small group of patients who are on another form of interferon. I'm not going to get into the intricacies. We can have it in the Q&A about the differences between the two, but generically these are both interferons. These are the 5 side effects I've picked. So flu-like symptoms are the commonest side effect that you may see, and most patients will combat that by pre-medicating with paracetamol. And in the era of these newer interferons, it's somewhat less, but it's by no means gone. It's a class effect. These drugs can also cause mood changes and depression, so avoid it in patients who have pre-existing depression. But if they have, if you deem it clinically important and the history of depression was maybe historical or not particularly troublesome and they understand that risk, then you can treat them. But if they find an exacerbation in their symptoms, you must stop it. Autoimmune disease is also concern with interferon. So so if you have a pre-existing history of autoimmune disease, so for example, like psoriasis is thought to be immune driven, so caution in patients with psoriasis, but we have seen patients with thyroid disease on interferon, so you should be having thyroid function checks regularly as part of your clinical follow-up. In very, very rare instances, and I've never seen this, but it is reported to cause eye effects. So we used to send all our patients to the ophthalmology clinic, swamp them, they didn't like that. So we just send them to the optician, go and get an eye check before you start your interferon, and then just go back if you notice a deterioration in your visual, if you notice visual deterioration. And finally, in very, very rare circumstances, it can cause cardiac problems. So certainly there's a caution about using it in anyone with significant, I think the information sheet says in significant cardiac disease. So we're cautious about using it in cardiac disease. And certainly if you have symptoms associated with any cardiac dysfunction, sort of breathlessness, chest pain, anything like that, then you should seek medical attention. Literally a couple of words on anagrelide, because not many of you will be on anagrelide, but anagrelide causes cardiovascular toxicity. So we talked about the anemia that anagrelide can cause. So it causes palpitation, so an awareness of your heartbeat, and that in itself is alarming, but it's benign. The problem is that is a cardiac symptom, And what it can do is, in rare patients, cause cardiopulmonary complications, and some of them can be very significant. And so it's all very well starting you on a medication that's causing palpitation, but at what point is that cardiac symptom actually a manifestation of more significant cardiac disease? So be aware, if you're on an agrolide and you have cardiorespiratory symptoms, you should be flagging that to your clinical teams. And then I said this was the cop-out slide, so I'll include this, but it is important. It's the commonest symptom whenever we do a clinic. How are you feeling, Joan? And first, I'm just exhausted. I am absolutely exhausted. So it is, and this is a universal symptoms. I'm not going to underplay, because you know it, how incredibly debilitating it is, impacting on work, on social life, on relationships, on everything. And there is no specific treatment for fatigue. But MPN Voice and Health Unlocked have got great tips on it. So, and again, Alice has covered a lot of this, so it'll be very brief. But, go to MPN Voice Health Unlocked and have a look. There's a section on fatigue. Professor Ruben Misa from the States has produced his top 10 tips for fighting fatigue. But they all essentially boil down to this bit in MPN Voice that talks about the integrative management, which is focusing on nutrition, exercise, and stress. So eating well with a balanced, nutritious diet, staying active, and managing your stress. There is no role for routine administration of herbs and dietary supplements. So there's no proven benefit. And if you are going to do that, please speak to your clinicians, because there can be significant clinical interactions. So in summary, we've talked about the symptoms of therapy. You are symptomatic, and report your symptoms, and it's the clinician's job to try and work out whether it's your disease, your treatment, both, or unrelated. You educate yourselves, which you are. You're an incredibly well-read and well-educated community, so you know what your side effects of your treatment are, so be aware of them and explore and use these resources, because they are moderated and they are excellent. And report concerning side effects to your MPN team. Discuss if dose modification would allow you to stay on therapy and would be beneficial, but ultimately discuss if switching would be more appropriate for you. Thank you for your attention, and this is the growing MPN team in Clatterbridge, Liverpool. Thank you.